you. Before we start, I wanted to read a statement of Indian and acknowledgement. The League of Women Voters of Marin County lives and meets in the ancestral traditional lands of the Coast Miwok people. We acknowledge and honor the Coast Miwok Nation and are grateful for the present day community of the federated recognized tribe, the Federated Indians of the Great Rancheria, comprised of direct descendants of the Coast Miwok. We also acknowledge other contemporary indigenous groups who live and work in Marin. So it's my pleasure at this point to introduce the chair of the Health Committee, Doug Cooper, who will introduce our subject and speaker for today's program. Doug?
Thank you, Kevin. So we are very lucky to have Rebecca Maxwell joining us. She's a licensed clinical social worker. She's going to discuss the work that she does with MarinHealth. I think probably explaining somewhat what MarinHealth is and its various parts. She's involved extensively in the behavioral health social services portion of that. So she's the director of behavioral health, social services, education, and inpatient palliative care, and she's been with MarinHealth since 2017. She earned her Bachelor of Science degree in Health Sciences with a concentration in public health and community health education at State University of New York, Stony Brook, and earned a master's in social work in their School of Social Welfare. In 2013, she was tenured as a clinical social worker at Stony Brook's Teaching Hospital. She has since then served in a variety of roles. I'm just going to pick a few out. She's been a case manager for court-mandated patients with severe mental illness, a clinical social worker in psychiatric emergency services and inpatient psychiatric treatment for adults and adolescents, assistant director of behavioral health at New York's John T. Mather Memorial Hospital, overseeing care of the adult and adolescent psychiatric units and the emergency services. So we are very fortunate, I think, to have Rebecca have moved here to Marin, and she now leads the full scope of behavioral health care at MarinHealth, including, I'm just going to mention a few, the 17-bed adult inpatient psychiatric unit, the partial hospitalization and intensive outpatient programs, the substance use navigator program, the electroconvulsive treatment program, and the outpatient behavioral health clinic in Novato. So she will take over now. She'll explain much more about that, I think, and also what's coming, new programs that MarinHealth and Rebecca are instituting. So take it away, Rebecca, and thanks so much for coming.
Thank you so much for having me. I really appreciate this opportunity to share about behavioral health services at MarinHealth Medical Center. I think before we get started, it is important to sort of make the distinction that all the programs and services that I'm going to talk about today are specifically related to services delivered by MarinHealth Medical Center, formerly known as Marin General Hospital. And I think it's important to make that distinction and not compare them to the services that are offered through Marin County's Health and Human Services. But we will get into and talk about our partnership with our county partners and more closely how we connect with our behavioral health and recovery services, because it's a very important partnership that we have with our county partners. I'm going to walk us through some of the programs that Doug had mentioned. There's a lot of content, there's a lot of alphabet soup and acronyms, and I'll do my best to sort of slow it down and talk through each of those points and give you a real high-level overview of what we do offer here. And then we'll get into some questions at the end. So with that, I think we have a presentation we can start sharing. Okay. All right, so on the next slide, we're just going to see the at a high level, these are the services that Doug had already mentioned. Most people aren't aware that Marin Health has a well-established and robust service line. Here are some of the programs that we have throughout our continuum of care, all the way from crisis intervention services through ambulatory clinic-based programs. In future slides, I'll go into more detail on each of these services. As a community hospital, Marin Health is really committed to addressing all the health needs of our community, our residents, and that includes mental health. In Marin County, if you're familiar with the Robert Wood Johnson health rankings, Marin County actually ranks #1 out of 58 counties in California as the healthiest county in all areas. But where we do kind of parallel and not do as great is actually in our mental health services and wellness. So for every 30 days, Marin residents reported 4.4 days as mentally unhealthy days as compared to 4 days across all of California. About 13% of residents report 14 more days of poor mental health per month. And this is really on par with other counties in California and across the US. And then 22% of residents report binging or heavy drinking as compared to 18% of other California counties and 19% across the US. And the number of deaths per suicide per every 100,000 residents is 14 in Marin County as compared to 10 across all of California. Fatal overdoses and drug poisonings have doubled in the past 3 years in Marin County and is the leading cause of accidental death, mainly driven by increased use of fentanyl. So as a community hospital, I'm very proud that Marin Health has committed to providing this high level of behavioral health support to parallel what our county services are also offering and really take care of the overall health and wellness, including mental health for our Marin County residents. Next slide, please. So we'll first start off by talking about our acute inpatient unit. So Marin Health is a 17-bed adult inpatient unit. Our adjusted daily census, or our average daily census, is about 16, a little bit over 16, but pretty much every day we are full. We very rarely have open beds, except when we discharge and pretty much readmit the same day. The average length of stay for patients on our inpatient unit is just a little bit over 10 days. And that is for a few different reasons. That's a little bit more than the national average for acute inpatient admissions. That usually runs anywhere from 6 to 7 days. The reason why I think we're seeing an increased length of stay, especially in recent years, is because people are having a harder time accessing care in an outpatient setting. So they're coming to us needing a lot more support and requiring longer time to stabilize. And then also in terms of access to subacute resources or where people go after they're admitted, those resources are limited as well. So we oftentimes have to wait for people to step down to lower levels of care in the behavioral health area. So our length of stay is slightly increased over the past few years. We are the only inpatient psychiatric unit in Marin County. We are a unit that really is focused on the overall safety and wellness of our patients. The majority of our patients are admitted initially on an involuntary status, or what you might know to more commonly as a 5150 detention. So these are our patients who are either a danger to themselves or others, or who present with a condition known as grave disability, which means they're unable to meet their basic needs. So they are detained in an inpatient setting for treatment. Even with that being the case, we actually compare ourselves to other hospitals in benchmarking and patient satisfaction surveys. And when we do this as compared to like hospitals, we have actually achieved the 95th percentile in excellence in overall quality of care as perceived by our patients. So our patients who have been to other hospitals and as compared to other facilities will state that we're really doing a good job and that they would prefer to be with our services. Part of that is the immense amount of support and compassion that our team has, and also the clinical expertise that our inpatient unit staff provides. that's made up of our psychiatrists. We have medical doctors who are psychiatrists. We have a hospitalist who supports the medical needs of our patients. We are staffed 24/7 with nurses and also have mental health counselors. We also have social workers and occupational therapists that support our program. When we've also focused on quality and safety, this is what we see on the right-hand side of it. It's a measure of hours of physical restraint or seclusion. These are pretty extreme interventions required for people who have significant behavioral dyscontrol or otherwise dysregulated. The lower number or lower hours of use are better, and we are well below the national and California averages. So it's just a measure of other quality interventions like behavioral therapy, medication interventions that we use in order to avoid such use as restraint and seclusion for behavioral management. So we really pride ourselves on some of these quality metrics. We can go to the next slide. This is just some demographic information related to our adult inpatient unit. So as you'll see here, our 18 to 30-year-olds currently make up 24% of our admitted patients, whereas this group made up 32% of our patient population in 2021. Our 61 to 70-year-olds rose 8%. They were 8% in 2021 and are now 15% this past year. So we are seeing an overall increase for some of our older adults as they are continuing to need behavioral health intervention, but still our young adult population is our most impacted and most in need. The majority of our patients are admitted from Marin County. This number has actually steadily increased over the past several years. So in 2021, the percent of patients admitted from Marin County were 48%. In 2022, it was 59%, and now we're at 66%. And I think this anecdotally really could be attributed to our collaboration with our Marin County Crisis Stabilization Unit. We actually share a campus with our county crisis service. So they're actually right next door to us. We work very closely with their clinical team. And we often share a lot of patients between county services and between our inpatient mental health unit. So we have regular meetings with our county partners. We meet on a monthly basis, and during COVID, we actually met weekly to really support the needs of this very vulnerable population. So I do think some of our numbers increasing from Marin County resident admissions are related to that. But we also we have to abide by EMTALA, which is the Emergency Medical Treatment and Active Labor Act, which means that anybody who requires who's in an emergency room who requires stabilization, and if we have an open bed, we need to provide that service. So emergency departments, our priority being our own emergency department at MarinHealth, so we get some of our admissions from there, but any other emergency department throughout the state of California, we're also taking admissions from when we have an available bed. When we look at sex assigned at birth, this is roughly split down the middle, and that has been steady throughout the years. That's been a pretty consistent demographic for us. And then when we look at our diagnosis, the majority of our patients come to us with a primary admitting diagnosis. And these are very broad categories, with psychosis being the predominant category for admission, followed by depression or major depressive disorder, and then mood disorder, bipolar, and schizophrenia or schizoaffective disorder may also make up about 20% of our admissions. Next slide, please. Here's a breakdown of race. The majority of our admitted patients on our inpatient unit are white at close to 76%, followed by those who identified as other or non-selected group. 6.4% of our patients identified as Black or African American, with 5% being Asian and less than 5% of Native American or Alaskan Native or Hawaiian Native or other Pacific Islander. About 14% of our patients identified as Hispanic or Latino, and this is a slight increase as compared to about 13% in 2021 and 12% in 2022. This generally aligns with the overall makeup according to the Census Bureau from January of 2022 for Marin County. So you are seeing a pretty consistent representation of our general population for admissions. Next slide, please. This is something that I like to share, even though it's important to, this is what our payer mix is. So this is basically how people who come into our services are basically insured. So the large orange circle there is those who are covered through Medi-Cal, followed by 19.6% who are covered through Medicare, followed by the commercial payers, so people who have more of a traditional plan like United Healthcare or Blue Cross Blue Shield or one of those commercial carriers. What's important to note here about this slide, and the reason why I do show this, is that a substantial portion of our patients are admitted to the unit, are insured or covered by Medi-Cal, which is close to 60%. But when you look at the overall demographic of Marin County residents, it's not the case that 60% are Medi-Cal, and demonstrates really that their persons with severe mental illness or needs require acute stabilization is greater than what is represented in the population, and that this need has increased and will continue to increase if we're not addressing other psychosocial factors and social determinants of health impacting this group. So next I'm going to talk about, on the next slide, I'm actually going to transition from our adult inpatient services to what we call is sort of a step down or subacute level of care. This is partial hospitalization and intensive outpatient treatment. So we call this PHP and IOP. This is a diversionary level of care for people either stepping down from acute inpatient, so that once they've stabilized and can manage at a lower level of care, they can come into our partial hospitalization and intensive outpatient program, or to help avoid a full inpatient admission. So people coming from who are currently receiving services, maybe they're not receiving any services for behavioral health, or maybe they're just seeing a therapist or psychiatrist once a month or once a week, but need a higher level of intensity. This level of care is here to serve as an intermediate level of care for either stepping up or stepping down from care. So these are hospital-based ambulatory programs that are a diversionary day treatment model of care, where patients can attend anywhere from 3 to 6 hours a day of treatment for up to 5 days a week at our partial level. And then our IOP level of care, people can attend 3 days a week for maybe 3 hours a day. For our IOP and our PHP programs at MarinHealth, we operate Monday through Friday, 9 a.m. to 5 p.m. Our treatment is in person. It's provided in the form of group therapy, individual therapy, individualized treatment plans, medication management, and support with our psychiatrists. We follow a cognitive behavioral therapy and dialectical behavioral therapy model of care to help individuals gain skills to better cope with issues related to anxiety, depression, psychosis, any of those diagnoses that we saw patients that were admitted for in our inpatient level is the same for what we're treating in the outpatient level. Again, similar staff demographic that we have making up in our PHP and IOP programs. There's just like psychiatrists, licensed clinical social workers, psychiatric nurses, and occupational therapists. In our programs, we currently have 3 specialty tracks that's focused on age-specific or stage of life needs. So we have an older adult program, generally 55 and older, but more focusing on probably closer to 65 to 80-year-olds. And for those who have either retired or are in the process of retiring and have more older adult specific needs. And then we have our general adult track, which is a crossover from our 25 to 55-year-olds, and then our young adult program, so 18 to 25-year-olds, although we're seeing a larger cohort of more 18 to 30-year-olds that are making up our young adult track. This slide, what you're seeing here is what we call units of service. The reason why I'm showing this here is it just gives us 2018 is your blue bar on the left, all the way to 2023 is our average monthly units of service. So what I wanted to show here is prior to COVID, we were really meeting a significant need in the community. And when COVID came, we could not, our primary model of care is actually groups. And we weren't able to meet in person for a long portion of the pandemic. So sitting, we did transition to Zoom, but I think you're trying to keep anybody's attention for more than an hour or two on a Zoom setting is pretty challenging, let alone providing intensive behavioral health therapy and support. So we didn't offer our partial hospitalization level of care for the majority of COVID. So we had a significant decrease in the number of our units of service. Not to say that there wasn't the need that was still there. In 2022, we were able to transition back to in-person, and now we're starting to see those numbers tick up, and really we're starting to get back into where we were in 2018, where we'd have several weeks up to 1 to 2 months of a waiting list for people looking for this level of care. So I'm happy to say that we not only are back in person, but now we've added this young adult track, which is pretty important to address, as you saw, that being our highest number of our highest demographic of patients requiring inpatient level of care. We really want to focus on these young adults who need support. Next slide, please. Again, we benchmark against other services and programs. So the Association for Ambulatory Behavioral Health Care is our standard of care when we measure against other PHPs and IOP programs. And what this slide is just showing is when surveyed against and benchmarked against other hospitals, we really want to meet for overall perception of care and meeting excellence. And there's a bunch of different questions that go into assessing a program's performance, if you will, including how patients perceived their recovery went, how much they participated in their treatment plans, how they felt they connected with their prescriber, how they felt that they met their goals of recovery. Our target is really to exceed the national average, and more importantly, to exceed the 50th percentile as compared to other hospitals. So our older adult programs and our adult IOP, that's the intensive outpatient programs, we do this consistently, or we are consistently exceeding that 50th percentile. Our PHP just coming back into service, we're still struggling to get consistent survey participation. And I think that's what's driving a little bit of our lower numbers, but overall, we are still providing some very high quality care according to our patients' perceptions. And this is really their perception that we're providing overall excellent quality of care. Next slide, please. So another branch of our behavioral health care is our social services department and our psychiatric emergency services. So social work at MarinHealth rolls up into our behavioral health program. And the reason why this is because our social workers are pretty important to the overall delivery of mental health care services. And we actually have a really, I like to call us a big little hospital or a little big hospital. We offer a lot of different specialty services for a community hospital. So we have a pretty robust social services department. We were just CDPH, our California Department of Public Health, just confirmed our licensing. So evaluated our social services program and said that we are meeting all of the regulatory requirements and hitting the marks with no corrective actions applied. So we just completed that in July. So we're proud of that. We have over 25 full-time and per diem master's prepared clinical social workers. The majority of our social workers are licensed, and some are on their pathway towards license. We provide actually their clinical supervision and a training program for them while they're in pursuit of their licensing. Those social workers will support our 5150 designation. That is the section of code in California that provides for people to, like I said before, to be detained against their will in order to have evaluation of treatment of mental health services. So we are one of the receiving facilities in Marin County. So we have to staff that service 24/7, and that's in our emergency department. Our social workers will also support our entire emergency department for other needs and our trauma center. We're also a level 2 NICU, our neonatal intensive care unit. So again, social workers will support the very specific needs for our neonatals and their families, and our adult psychiatric unit, our adult medical inpatient units, and our pediatric units. We also have social workers supporting. We also have outpatient palliative care and oncology and inpatient. And then one thing, we'll talk about this a little bit later on, is our psychiatric consultation-liaison service. I'll get into a little bit more detail, but our social workers are very integral into that service. Through our designation, our psychiatric emergency services, as I said before, being the 5150 receiving facility, we very much closely collaborate with our county behavioral health and recovery services to support the needs of all the county for people who either present to our emergency department in crisis and need admission, or partner with our county crisis stabilization to prioritize and support those patients who need either a higher level of care or referrals to outpatient support. Our social workers are busy. They're very busy. We actually, in the emergency department, outside of the psychiatric cases that they support, they'll see close to 5,500 cases that they'll directly be involved in. Those are for all range of things related to social determinants of health, referrals to outpatient care, or even just-in-time crisis intervention to support anybody who's presenting to the emergency department or trauma service. And then here you'll see of those 5,500 patients, approximately 1,000 patients and families are supported by our social workers that present with a primary psychiatric need. From those numbers, as you see, about half of them are discharged home or to a subacute level of care. About a quarter will actually be admitted to an outside psychiatric service or another psychiatric inpatient unit, or to our county crisis stabilization unit. About 20% of those patients will get admitted to our medical service, and then also have co-occurring needs to be followed up by our psychiatric service or consult liaison plan. And then about 9% will actually get admitted to our adult inpatient unit. And our social workers coordinate all that care for those patients and families. In the next slide, I'll talk a little bit more about our behavioral health continuum. So some of you may or may not know about ECT. So some of you may or may not know what ECT is. And if you do, you may have notions about it's electroconvulsive treatment. You may think of it in some of the more sensationalized or former barbaric ways in which ECT or shock therapy was performed in the past. But that's very much not what ECT is in modern times. ECT is actually a very humane, life-saving intervention for people who are not doing well with other forms of interventions for treatment refractory depression or catatonia or other psychiatric illnesses. It really is life-saving. Where other things have been tried and have not been successful to support people, ECT has been truly a lifesaver, and is done in collaboration with our surgical services. It's a procedure. It's done with an anesthesiologist, by a psychiatrist, and actually delivers. It induces electricity is used to induce a seizure that sort of resets how the brain is working, and helps sort of improve symptoms of depression and catatonia and other psychiatric illnesses. We do it both on an inpatient and an outpatient basis. We're the only provider in the North Bay that does this. We average about 1,200 cases per year. We have a several-month waiting list for this service. And we're looking actually to expand one of this program specifically in the year to come. As I mentioned before, when we were talking about social workers, the psychiatric consultation liaison service, this is a program that I'm pretty excited to have in a community hospital. It's something more that you would see in a teaching hospital or a larger academic center. And it's usually run by psychiatry residents. But here at MarinHealth, because we're the designated 5150 receiving facility, and because a lot of our patients will present with both medical conditions, significant medical conditions, or co-occurring mental health issues, we want to treat the whole patient, and we don't want to wait for one issue of their care to resolve and then move on to another. We want to treat the whole patient at the same time. So we actually have a psychiatrist and a clinical social worker that will support the patient as a consultation throughout their medical stay. So these are some of our most complicated admissions. As you saw on the slide related to social services, about 20% of the patients that had presented with a primary psychiatric need had to be admitted to the medical floors, and that could be related to a suicide attempt or a significant medical issue that they needed treatment for, but they still have very pertinent, present primary mental health need that needs support. So we partner with our intensivists and our hospitalists and the interdisciplinary team to support the patient through their continuum of care. And what we've seen through close to these 300 cases we see a year is that length of stays in the hospital is not extending for these folks. In fact, it's going down, and we want that to happen. We don't want people to be in the hospital any longer than they have to be. And we find that when we provide this level of consultation and support for the patient, that their outcomes are better and that their length of stay is less. And it's also a service to provide some information and support to our colleagues that are treating these patients. So to the other doctors and staff and nurses that are providing care, we are the behavioral health experts that then give them some tips, advice, and guidance on how to help support these patients better. And then this is a program that I'm really excited to talk about. It's our Substance Use Navigator program. So a Substance Use Navigator we've had this position now going on 4 years, and this is a grant-funded position that we have. Our Substance Use Navigator program and the Navigator actually helps patients access evidence-based treatment for substance use disorders with a focus on low threshold access to medication-assisted treatment, or what you might know as MAT. This also has a focus on harm reduction. So people with substance use disorders, we really want to make sure that they're not only getting alternatives for their treatment but that we're also helping to support them through their continuum of care and connecting them with outpatient support. So our Substance Use Navigator will conduct some outreach and identify patients who are admitted to our emergency room and our hospital services. They'll conduct a brief assessment around their substance use disorder, their readiness for change, and then introduce patients and providers to medication-assisted treatment. So you might have heard terms like Suboxone or buprenorphine or naloxone. These are medications that help those who struggle with substance use disorder decrease cravings and minimize their use of things like opiates and alcohol. The Substance Use Navigator will also help facilitate appointments to outpatient MAT clinics or serve as a resource to coach and support clients and providers and advocate for change throughout the hospital. So in addition, I mean, this is just 300 patient encounters in the past year that our Navigator has supported, but there's also a big focus on educating our staff and community about stigma and reducing stigma related to substance use disorder and really helping connect people beyond the hospital to treatment and care that they can benefit from and hopefully avoid future hospitalizations and decrease the time that they actually do spend in the hospital. The 31st was August 31st was International Overdose Awareness Day, and our Substance Use Navigator and our social work manager actually held an informational booth here at the hospital and talked about what Narcan is and how that can help people who are, anybody should have access to Narcan. So that way, if you find somebody that's overdosing, this can immediately, overdosing related to opiates, this can immediately impact, and provide reversal for that. So we want to, again, help decrease avoidable deaths related to substance use. And this is just a great program that I'm proud of here at the hospital. And then further along, next slide, is our outpatient ambulatory clinic. So I'm kind of walking you through all the continuum from crisis, acute services, and now we're going to bridge out into the ambulatory world, which is our mental health clinic. And this is either, you can kind of equate it to your primary care prevention or a primary care treatment model in behavioral health. But very proud to say that our hospital has supported access to a psychiatry clinic. So about 2 years ago, we opened up our ambulatory psychiatry clinic in Novato. These are our staff members. We're actually adding to that this month. But since opening in 2021, we've impacted close to we've had actually 6,000 unique patient encounters, and it's well over 650 at this point. This is data from up through July this year. So at least 700 patients that we have actually been able to impact and provide support through either medication management, group therapy, or individual and family therapy. So it's pretty exciting. If in MarinHealth, I think it's if you have resources and means, you can pay out of pocket. We have a lot of providers that provide access to therapists and psychiatrists, but you really have to have the ability to pay for that out of pocket. We're one of the only clinics that actually will let folks use their insurance benefit. So it's a pretty important resource that we're providing to the community, because it's not one that the general resident or community member might have access to. And we're looking to grow this service. So we're in the process of partnering with some of our specialty services, like our cardiovascular service line, to support those folks who are dealing both with their medical issues and mental health issues. We're looking to embed mental health clinicians into our primary care clinics. So where you would go see an internal medicine or a pediatrician or your primary care provider, we would also like to have behavioral health care right there in the office available and there to support you through both. And again, treating the whole aspect of the individual. And then we're actually, in a couple of weeks, we'll have another child and adolescent psychiatrist starting to our service, which we're starting to bridge into supporting that level of care through primary support in our ambulatory clinics. And then I'll get into a little bit more of a program expansion in the next slide. But Dr. Schwab is one of our child and adolescent psychiatrists, and another one will be joining us, Dr. Tipton, in a couple of weeks. So we're pretty excited to be able to address this very much in need area of child and adolescent intervention and mental health support. And on the next slide, looking specifically at adolescents, we know that our young, again, kind of going back through the data, our young adults being that highest, our 18 to 25-year-olds being that group that really requires the most intensive level of support. We wanted to get ahead of this and really offer some more support. In addition to the clinic services that we have, we're looking to add another whole service line of our program, and that's an intensive outpatient program. So similar to the second program that I had discussed earlier on, and our intensive outpatient program will be based at the hospital. We're going to focus on 12 to 17-year-olds with a primary behavioral health diagnosis. These individuals will attend 4 days a week for up to 3 hours a day. We can have at any given time 8 to 12 participants in a rolling capacity. We're in the process of redesigning one of our spaces at the hospital to support this, and we're hoping to actually have this program launch in 2024. On the next couple of slides, I just wanted to show like a high level view of what the space will look like, and we can kind of breeze through those. But the focus of this program is really to support a very much unmet need of support for adolescents experiencing significant issues related to anxiety, depression, suicide, self-injury. This program will really focus on providing adolescents with life skills, coping skill development, and some support related to medication management and individual therapy. What it will also do, we'll offer this later in the afternoons so that students can either have the opportunity to attend some classes during the day and not get behind on their academics. And we're also looking to partner with school accreditation, so that way children can actually earn credits while also attending this. So we really don't want children to fall behind while they're also addressing their mental health needs. So we're very excited about this as we look forward in 2024. And on the next slide, this is just an image of what some of the design spaces in the process of being built. There's 2 group rooms, a larger general common area, and a patio area, and a consultative space, and it's on this very protective, safe therapeutic. So that's we're hoping will be done in the next couple of months, and we'll be ready for opening in 2024. And on the last slide is just a picture of that garden space. This is just a rendition of what we're looking to have right off of that group therapy space. We'll also have a nice patio and outdoor space where we can also provide some programming and some therapeutic support. So it's not this traditional walled-in office space, but also, taking advantage of the beautiful space that we have here and providing additional therapeutic support. So I'm very excited that will be one of our projects upcoming. And I think that takes us to the end of all of our programs. So I will stop there and open it up for questions.
Rebecca, I don't see any questions in the chat. I don't think I'm missing anything. If anybody wants to ask a question, at this point, you don't have to put it in the chat. You could just, hit the reaction button at the bottom, and where it says under that raise your hand that way, and we'll be able to see that. And I'll call on you. I've got a few questions. You mentioned access and problems with access a number of times. I'm wondering if you train any new providers, and whether you do or don't, have you considered collaborating with local colleges or universities to sort of have new providers come intern in your facility?
Yeah, that's a great question. So we actually do have partnerships with for all different services, so or professions. So we actually partner with a lot of local universities for nursing, mid-level providers. We have a partnership with UCSF. We're not a residency training program. So as far as providers, when I say psychiatrists specifically, our doctors have a good relationship with UCSF, but we don't actually have a training program for residents. But we do have partnerships with local schools for social workers and nurses. So, and we do offer internships, and that's actually some of the way we've had several of our hires getting into our hospital-based programs is through internships, and then subsequently supporting them through licensure. I think the biggest, to expand upon that though, yes, we have challenges with people wanting to stay in a system and not maybe go out to private practice, because it's much more lucrative for people to leave to be in private practice and take cash. So we really want to create programs that are very high quality and collaborative and drive really good interdisciplinary work and really focus on systems of care. And that's how we've been able to grow some of our programs and retain some of the providers that we have in terms of both the psychiatrists and social workers. It is pretty important to have a high quality program to retain these providers.
Anybody else? I don't want to hog the questions. You showed a slide where you had almost 60%, I think, of the inpatient unit were being the reimbursement was coming from Medicaid and or Medi-Cal. So how do you where do you get the rest of the reimbursement for, because that reimburses so poorly? Does that come from grants? Does it come from the county? Does it come from some other state source? How do you pay off? I mean, you're covering so much of their care separate from Medi-Cal.
Yeah, that's a really good question. And really, it's just been a commitment of the hospital to basically absorb those costs. We recognize that while we're not making money, if you will, like other services throughout the hospital, as a community hospital, it's something that we've committed to basically absorbing the costs and loss related to that. We do get some funding from our district. So being a healthcare district hospital, there is some funding from our district hospital to support several of these very key programs. So we do have some cost offsets, and then we do have some philanthropic support again for other programs. In fact, that garden, the rendition that you saw of the garden renovation, that was directly related to a community donor. So we do partner with some philanthropic support to offset some of the losses that we do see in mental health.
So I'm going to call on Jackie next, Jackie Dagg, and then after Jackie, Jan King. Can you unmute Jackie?
Sorry about that. Rebecca, I have a couple questions. What's your opinion as to whether a 17-bed facility is adequate for the Marin population? And then also, are you finding when that there's adequate placement facilities in Marin or elsewhere when patients are discharged from the acute facility?
Great question. So I've worked in behavioral health for close to 20 years at this point, and in terms of capacity and meeting the need, I don't. It's a hard question to answer. I think there's always going to be a need for inpatient psychiatric beds until we get a better sense of equity and parity around primary prevention support services for mental health. So do we have enough beds to support the need, not only in Marin County, but in all of California? Again, we admit from all over the state. Do I think we meet the need? No, I don't necessarily think that we do, but again, I don't know that's where necessarily we need to focus our efforts on. To that second point, when we talk about subacute, and I think your second question was around access to subacute level of care. That's another area I think that as a diversionary level, both to inpatient admission or stepping down from the hospital, there's definite opportunity where we could increase that capacity and then support our patients and our individuals better outside of the hospital. The hospital is a very restrictive setting, and it's something that it really should be the treatment option of last resort. So looking at more of these residential placements or crisis residential units or subacute longer term placements, or even, wraparound services like supported housing and case management and full scope case management. And I think this kind of gets into more policy and broader scope things. When you're somebody who has Medi-Cal, you actually have the ability to get sort of these wraparound support services, and a little bit more better care in mental health, whereas people who are commercially insured may not have access to subacute placement or to case management support or wraparound support like supported living. So even in mental health and how you're the payer, there's a significant disparity in access to care. So things that I think the mental health world has been struggling with for years is how to provide comprehensive primary prevention supportive services. That's where I think more effort should be focused on that subacute and not focusing on inpatient hospitalization. I hope I answered your question.
Yes, thank you.
Okay.
Jan, you want to unmute?
Sure. Actually, my question was also about the number of acute beds, and you answered half my question. The other half of my question is are most of those beds occupied by 5150 referrals?
Yeah, yes, that's the majority for the inpatient hospitalizations. The majority of our patients are initially admitted on that detention status, right? So, there's two types of detention. There's, civil detention and, probate, criminal detention. So this is a civil detention status, that 5150 referral, if you will. Almost all of our patients are admitted in that respect. And I have to say, I'm very proud of our unit. We convert people to what we call a voluntary status as soon as we are capable of doing that. So the majority, even though we have longer length of stay, the majority of our patients are not being detained on that 5150 status any longer than they truly need to be. In fact, we try to make people voluntary much more quicker, I would say, than other hospitals. We really want to have people be autonomous, promote their pathway to recovery and support. So sometimes they stay because they're just trying to get better on their own, and we're waiting for a subacute level of care. But
I see.
Almost 100% of our patients are admitted initially on that initial detention.
I see. That makes sense. And then are many of your referrals, are they unhomed people?
We do, I don't have the actual numbers of data, but around that, but we do have a significant portion of that population. And that's when we see that Medi-Cal group, that 60%, there is a significant portion, obviously, that are impacted by other social determinants of health, like homelessness, food insecurities, things like that. So we do have a number of those folks that don't have access. And that's, again, that higher need for that subacute level of care, like crisis residential units or step down, or even, board and cares that could support people who don't have significant means or reasonable shelter, right?
All right, good. Thank you so much.
Rebecca, do you collaborate? Do you work with the special courts, the mental health courts and the drug courts and so on? Do you end up finding that those people transfer into your care?
Sometimes they do, and um, sometimes there is crossover. And again, oftentimes those individuals are very closely connected and already supported by our county behavioral health and recovery services teams. And again, we very much have ongoing case consultation and collaboration with that group as to how to best support them, both from the inpatient level and for when we see those individuals through our emergency department. So not with a significant level of frequency does that happen. If somebody's actually in detention, we would not, because we're not a forensic facility. So, but if there's people aren't necessarily referred to us either as a diversionary. They just may come into us because that's just their medical need at that time. And they may also be connected to those support services. But that's where we partner with our county BHRS team members to help support those individuals, both through their hospitalization and to their next level of care.
Anybody else? I noticed on the website that you have a gender affirming surgery or care medication program, and I was just assuming a lot of those people probably need your social work, behavioral health support. Do you cooperate with that program?
We do. We have a good partnership with that team. However, that program is, I have to say, our director, Amy Blevins, is our nurse director of that program, and she has a very good collaboration with folks that are being referred to us and with some outpatient support. So there's a pretty robust effort to support those individuals both prior to surgery and then post-surgical. So oftentimes they are already well connected before coming into our care. But if there ever is a need, certainly our team is aware and supportive, and we do collaborate with that service. Yes. But that's a great program that we have here.
That's good to hear.
Yeah.
Well, it sounds like you've got a lot of great programs, so doing a great job. Anybody else? Well, I'm going to repeat something that Rebecca mentioned before we started the meeting, which is that if you send questions to me, I'll forward them to her and she'll get back to us. So don't hesitate if you think of something that she didn't cover or couldn't cover today. She's willing to try to get the right answers to us however she can. And we will, I think Dee Dee will explain this. We will be this recording will be processed and then we'll post it on the website. So you can watch it again or recommend it to someone else, or those people who couldn't get to the meeting, tell them, yes, you can watch it later on the website.
And Doug, I'll share, if you want, you can share my contact information. I know I kind of gave a very high level overview, and each of these programs really there's a lot more meat and content to a lot of the services that are being provided. If you ever find that you have somebody who's looking to access care, if you ever have anybody who's looking to just find out more information, always happy to be able to speak to somebody, connect with somebody individually, or even if you're just looking for guidance around what's available for my friend or family member, please feel free to reach out to me directly. That's something we always want to make sure. Again, we're decreasing barriers to accessing care. We just want to make sure people get to where they need to with the limited resources that are available. So if you ever have any questions or concerns, please don't hesitate to reach out to me.
Thank you so much, Rebecca. So I'm going to stop the recording and end the meeting now. And we look forward to chatting with you in various contexts in the future.
Great. Thank you.
Thank you. So long, everybody.